Good morning, good afternoon, or good evening, or good night, depending on where you are joining us for this session today. Thank you so much for joining us on this session on advancing global registries in sickle cell disease. My name is Donnell Ivy, and I am the education coordinator for the Sickle Cell Awareness Group of Ontario, as well as the chief medical officer for the Sickle Cell Disease Association of America. In addition to that, I am also an individual that lives with sickle cell disease. When I was born in the early 1970s, there were not a lot of treatments for sickle cell disease, but fortunately, we've made quite a few advancements, and now there are several therapies and treatments for sickle cell disease, including hydroxyurea. I have been fortunate enough to benefit from hydroxyurea that has allowed me to not only finish my undergraduate education, but go on to medical school and then to a career in helping others with sickle cell disease. Unfortunately, we know that not everyone has equal access to these therapies. And so it's important that we use registries and other data to look at where individuals are, and then how do we align the resources for individuals so that they may benefit from the therapies and the advancements that have been made. So I want to thank you for joining us today to talk about a little more about this. Our first speaker is going to be Professor Adekunle Adekile. Dr. Adekile graduated from the University of Ibadan, Nigeria, and completed his postdoctoral fellowship in pediatric hematology at Howard University Hospital in Washington, D.C. He was a Fogarty International Fellow in Molecular Genetics at the Medical College of Georgia in Augusta, Georgia. Until recently, he was also the professor at Kuwait University in Kuwait. He is an adjunct professor at Emory University, Atlanta, Georgia, and also at the University of Abuja in Nigeria. Additionally, Dr. Adekile is also the chair for the GANSID. Thank you so much for joining us, and I now turn it over to Dr. Adekile.
Okay. Thank you very much, Dr. Ivy, for that introduction. And it's my big pleasure to be here this afternoon for me, morning for you guys. And I'm going to be talking about what we've been doing in GANSID about starting a global sickle cell disease registry. And this is my agenda for this talk. I want to establish why it is important to have a global registry for this disease, looking at the distribution and the heterogeneity of the disease, and then talk about some of the peculiar issues in the low and middle income countries, see what kind of registries exist as of now, and then see what GANSID brings to the table in terms of being the nucleus for a global registry. Now, as we all know, sickle cell disease is about the most widely distributed, clinically significant genetic disease. And there are like estimated 20 to 25 million people that live with the disease as of now. Unfortunately, most of those are in sub-Saharan Africa, where like 80% of the estimated 500,000 newborns with the disease exist. Compare that to what we have in the US, that we have only about 100,000 affected patients. And if we look at Europe and some other parts of the world outside of Africa, the numbers are even less. However, a country like India has a big burden of the disease, especially in the tribal population. And as we know, 2 years ago, the Indian government committed to eradicating or eliminating sickle cell disease by 2047. So there's a big drive backed by the government to deal with sickle cell disease. And in the last 2 years, they've screened more than 60 million people and detected 215,000 affected patients. Nigeria that probably has the highest burden of the disease worldwide. We don't have firm figures, but we know there are millions of patients, and up to 2% of all newborns are affected, which translates to about around 50,000 affected babies annually. And just to tell us, shows the fact that sickle cell disease is so heterogeneous. I mean, there are different subtypes, there are different phenotypes, there are different haplotypes, and somewhere like the Arabian Gulf, as a matter of fact, has the most diverse sickle cell disease in the world. We see all the subtypes, SS, S beta thal, SD, etc. And in fact, the only dominantly inherited sickle allele is found in that part of the world, and that's the hemoglobin S Oman, where heterozygotes have a full-blown sickle phenotype, and homozygotes are so severe that they do not survive. Okay, now we see all the different haplotypes, the Arab Indian, Benin, Bantu, but when you compare these haplotypes to those that we see in Africa, they still have some peculiar polymorphisms that still differentiate them, just to tell you how complex sickle cell disease may be. And therefore, in that part of the world, we see both the mild and the severe clinical phenotypes, okay? And when you compare that to what we see in India, where the patients have about the same kind of genotype or haplotype as the Arabs in Eastern Arabia. However, phenotypically, they are quite different, you see, so that it's not just the haplotype that translates to the phenotype, and we may suspect that there are some other epigenetic factors, okay, that are operating. So this just tells you how complex sickle cell disease can be. And then when you now look at patients in the low and middle income countries, there are peculiar issues. First of all, many of the countries have very high prevalence figures, and it's been estimated that in Africa, there are at least 7 countries that have prevalences of more than 1% in the newborns, okay? At the same time, there are poor levels of awareness. There's extensive stigmatization, both cultural, in schools, at work, and unfortunately, even in hospitals. Okay, they face this stigma all the time that compounds the issues that the patients have to deal with and translates to a lot of mental stress, okay, for these patients. Again, diagnosis and treatment facilities are not, they're far from being optimal. Mortality is still very high. And there are all kinds of logistical difficulties in terms of infrastructural deficiencies, power supply, road networks, severe terrains. Okay, so all these make looking after sickle cell patients in that part of the world quite challenging. And these are all issues that we need to document so that we can do proper planning. Okay. Now, unfortunately, there aren't really big registries. Many countries and hospital settings have their own limited databases, okay? But at best, these are fragmented, and quite often they are research-driven, and therefore they depend on the funding that is available for the research project at the time, so that sustainability and continuity are kind of compromised. And with the existing registries, there's poor connectivity and accessibility, and compatibility, okay? Probably the most robust registry so far that has been published is the work from Sickle in Africa, which was published in the last few months, where they reported 13,403 patients, from 31 different facilities in 3 countries in Africa: Ghana, Nigeria, and Tanzania. So this is a very good start. But then, you see, when we're talking about 13,000, 20,000, in a situation where we have millions and millions of patients, so we're still just scratching the surface, okay? Now, from what I've just presented, we see that sickle cell disease is different from place to place. And even in the same patient, it evolves with time. Okay, that's why we need a broad overview in a holistic manner to actually be able to, appreciate the depth of the issues. Therefore, a global registry was going to enhance research and insights. We're going to have a better understanding of the clinical or the natural cause of the disease in different parts of the world, the epidemiology, the treatments that are available, and the outcomes and other innovative trends. And of course, this will also enhance education and awareness, not only among clinicians or caregivers, but even the patients and the public at large. Okay? And that will necessarily translate into better outcomes for the patients in terms of their care and adoption of best practices and management guidelines. And again, it will going to facilitate policy planning and advocacy at all levels so that stakeholders will be equipped with real-time and up-to-date data for planning. Okay. And of course, there's going to be building of the global network that would enable international interactions, learning, and sharing of knowledge. Oops. Okay. Now, where does GANSID come in? Now, GANSID is the Global Action Network for Sickle Cell and other inherited blood disorders. It's been in existence for a few years now, and it's been quite successful, such that as of today, there are at least 125 patient and affiliate organizations spread across a little over 35 countries. And there's been very robust interactions. There's been, very big interest expressed in GANSID initiatives. And there are several, programs and initiatives that GANSID, has from mentorship programs to educational modules and all that. But the Global Registry, Sickle Cell Registry, is one of the biggest ideas or initiatives that GANSID has. Okay, and the way GANSID is organized, like I said, GANSID is present in at least 35 countries in all the different geopolitical zones of the world. And the organizational structure is quite robust because all these different zones are linked. We have working groups that supervise what's going on. Then we have regional leads, and there's a robust WhatsApp forum for each of the different areas so that people interact. And we have a chief executive officer who has been very active, very energetic, very resourceful, okay, who has been handling, coordinating all the activities. And there's a board of directors that, oversee all that is taking place, and I've been quite privileged to chair that board in the last couple of years or so. Okay. Now, so one of the working groups that we have is the scientific working group, which established the Industry Advisory Council, IRAC, which brings together different representatives of pharmaceutical companies, okay, along with some of us physicians and patients on that council, and they are those the people that are driving this interest or this strategy that GANSID is in a position to host or be the focus, for a global sickle cell disease registry. Okay, and so we have initiated consultative meetings, in the different parts of the world where we are present. We've been assessing all the regulatory frameworks and the technical capabilities in each country. And in many of the countries, we've held seminars in person and webinars, with clinicians, patient organizations, and the need to document sickle cell disease patient data in a global registry has come out as something that everybody desires. And we already have a template that that we can learn from, and that is the World Bleeding Disorders Registry that is organized by the World Hemophilia Federation, and that is working very well. Okay, so we've also held meetings at many sites who have existing registry initiatives in Nigeria, for instance, in India, and a few other places. And we've been trying to identify what the gaps are. What are the platforms currently being used? And again, documenting this interest in having a global registry. We've also met with government officials, IRBs, and national regulatory frameworks. We've been studying exactly what is in place in many of these different places. And so far, we've had overwhelming interest in all the sites that we've engaged. And after looking at many available instruments and companies that have expertise in international registries, we decided that we go with BCB Medical. And the advantage of BCB Medical is that they're the same group or company that works with the World Hemophilia Federation and runs the World Bleeding Disorders Registry. So they have the expertise, they have the experience, okay? And now we know that this has to be done in phases if we're going to do it successfully. And we would need to have a few pilot centers to start with. And it's going to be in phases. There's the definitions phase, and I'm going to talk about that in the next slide. And so far now, we have actually identified 7 pilot centers in 5 different countries. Of course, we can't disclose what the pilot centers right now, but a lot of work is still
Dr.
going
Adekile,
on.
2 minutes.
Thank you. So what are the outcomes so far? Okay, now there are challenges, of course, when you want to do this kind of big project on an international level. One of the big things, of course, that we have to take into consideration is patient confidentiality and protection. The data have to be depersonalized and password protected, and we have to be compliant with local IRBs and regulatory bodies across different national jurisdictions. We've got to have a platform that is acceptable, that is user-friendly, and whether probably if we use a proprietary software, but it has to be able to communicate with existing formats and existing platforms like the REDCap. And it's so important to have standardization of data so that we are all collecting uniform, interpretable data. And the question of governance is a big issue that we have to work through in terms of have good data use agreements, sharing of data across countries. We need to walk through all the regulatory procedures that are required. And we have to find a way of incorporating existing collected data without jeopardizing the influence or the interest of those who worked on those data. But if we can't communicate or we can't share data, then the whole effort is probably going to be in vain. So that's something we have to work through. And of course, the big elephant in the room is funding, because for sustainability, we have to obtain funding, and there are good prospects that we are seeing. Okay, so the next steps, we have to expand and enhance our consultative efforts with more stakeholders. We have to engage governments and regulatory agencies, funding, like I mentioned, and then we have to phase this and decide on what we do at the different phases. Of course, we have to decide on the platform and then the data to be captured, and then we roll out training for all the stakeholders that will be involved. So I think that's my last slide. Thank you so much for your
Thank you so
attention.
much for
Hopefully,
that presentation, Dr. Adekile. We, of course, want you to stick around because we imagine there'll be a lot of questions about what GANSID is doing to improve access to sickle cell disease through using registry and using data. Our next presenter is going to be Dr. Catherine Chunda-Liyoka. She is a distinguished pediatrician specializing in hematology and infectious disease. She holds the dual role of consultant pediatrician and head of the pediatric hematology department at the University Teaching Hospital, Children's Hospital in Lusaka, Zambia. In addition to her hospital duties, Dr. Chunda-Liyoka is a dedicated educator and researcher. She serves as an honorary lecturer at the University of Zambia and is an honorary fellow at the Liverpool School of Tropical Medicine in international public health. Her research and programmatic interests span sickle cell disease, pediatric malignancies, HIV, and implementation science, particularly in sub-Saharan Africa. Thank you so much, and I look forward to your presentation.
Thank you very much for the kind words. Just allow me to Are you able to see my screen?
Yes, we can see it, but you're not on slides.
Okay. There you go. So thank you very much once again for those kind words. And thank you to the organizers of GANSID for the invitation to be part of this Congress and also to be...
You're still not displaying your slides. The page we see is, I think, in your Acrobat.
Are you able to see that?
Perhaps you can stop share and then share your presentation and try again.
Okay.
Are you using multiple screens potentially? Or just one screen?
I'm using one screen.
Okay.
Yes. Are you able to see that?
Yes, we can see them now.
Okay, thank you. So I'd like to extend my thanks to the previous presenter as well, who has laid, I believe, a good foundation for the presentation I'm about to share. So I'm discussing building on the Sickle in Africa Sparkle data collection program in Africa, and case in point, I'll be making reference to Zimbabwe and Zambia's experience within the Sickle in Africa consortium. So my name's Catherine Chunda-Liyoka, as has been introduced. So as a background to this presentation, we know that amongst the places with the most prevalence of sickle cell disease is sub-Saharan Africa. And the countries within sub-Saharan Africa also have reported very severe limitations in the standards of care, in the management strategies of sickle cell disease. They have reported limitations in the skills of the health workers in managing sickle cell disease patients, as well as limitations and sometimes non-existence of databases to provide information that would help in monitoring the clinical care of these patients. These limitations, of course, have resulted in a hindrance in research and also the healthcare standards. Some of you may have read the Lancet Hematology Commission report, which has indicated that although there is substantial body of data that has been assembled on the distribution of the disease, reliable, precise, and representative data is really lacking in these sub-Saharan African countries. And therefore, the Sickle in Africa consortium comes to really bridge the gap in those limitations and hindrances that have been reported So Sickle in Africa is comprised mainly of these three groups, which is the Sickle Pan-Africa Research Consortium, SPARCO, and also the Sickle in Africa Data Coordinating Center, which is SADC, based in Cape Town in South Africa. Then there's also the Clinical Coordinating Center within SPARCO, which is being led by Tanzania. And then we have the Sickle Cell Pan-Africa Network. So this consortium has gone through two phases of activities. The first being the first phase that ran from 2017 to 2021, with the countries Ghana, Nigeria, and Tanzania being part of that. And later on from 2021 up to next year, 2026, 4 more countries have been incorporated, and that is where Zambia and Zimbabwe has become part of this consortium. So the main goal really is to create a large-scale multinational data set that can be used to conduct research, to track patient outcomes, and of course, to develop better management standards within the sickle cell disease community. And among its many objectives is that of forming a centralized electronic patient-consented sickle hemoglobinopathy database. So when the consortium began, the idea was to really just register patients. And with time, it was decided that they were actually going to be following up these patients long-term. Within the different countries, different follow-up times have been agreed on, with some following patients every year, every 6 months, or every review, according to the guidelines of that particular country. Within Zimbabwe and Zambia, we decided, with our limited resources, to be following up patients every year. And in terms of data that is being shared, there are core data elements that have been agreed on that can be shared within the consortium. But then there's also additional data or variables that the different countries are at liberty to choose whether to include them in the database or not. All these activities of course, have been integrated as collaborative consortium activity, working together with the National Heart, Lung, and Blood Institutes, working together with, of course, the Data Coordinating Center, Observation and Monitoring Board, and there's also quite a bit of training that is taking place as well within the consortium. The consortium has also released guidelines that have been formulated within this consortium, and these are available for other countries that are not part of the consortium to access. This also helps in standardizing, of course, the data that is being collected, because then we are all following the same standard guidelines. There are guidelines for management of sickle cell at tertiary institution, at secondary, at primary, and more recently, management at home level, for community health workers and to those that are offering care to the patients, has also been released. There has also been quite a number of research activities that have taken place going along with clinical skills development. All this at the end has been working towards planning cohort studies or implementation of research. Of course, that would take us a step further in terms of improving what we know about the sickle cell disease patients. So in May, and this was alluded to by the previous presenter, in May of this year, the first phase of the consortium released data on the work that they were doing. In this particular phase, about 13,403 sickle cell disease patients were enrolled between the period 2017 and 2021. This was done in 3 countries and across 13 facilities. Within this report were estimates and reports of the prevalences of diagnostics and therapeutics that is being offered to these patients. In the next slides, I'll just share some of the information that came out of what was reported. So they noted that age of diagnosis was quite variable across the three countries, with Ghana having age of diagnosis at 3, Nigeria 19 months, and Tanzania 3 years. It was thought that all these differences were a reflection of differences in country-specific newborn screening programs and policies, with Ghana, of course, having been the first country that began the newborn screening program under the guidance of the late Professor Koff. In terms of hydroxyurea usage, again, quite variable results were reported, with again Ghana, the country that had begun newborn screening early, having an uptake of 21%, hydroxyurea, Nigeria 12%, and Tanzania 6%. So reviewing this data, it was thought that the two countries, Ghana and Nigeria, did have arrangements within their countries where patients were accessing the drug through medical insurance coverage. That was in Ghana. And for Nigeria, Nigeria had partnered with private and public partners to establish a unit that was actually manufacturing hydroxyurea within the country. And this has actually continued even up to now. It was, however, also noted that initiation of hydroxyurea was not correlating with age of diagnosis, but relating with the age at which a patient was diagnosed with the disease. So this also highlighted the fact that clinicians may not be aware that when they do the early diagnosis of the patient, they should begin treatment and not wait until the patient is enrolled in care as well. Another very interesting fact that came out from this paper was that males were more likely to receive blood transfusion or to receive hydroxyurea. And it was postulated that maybe the severity of disease that is reported in males could have been the reason why they were the ones receiving blood transfusions as well as the one receiving hydroxyurea. However, when they looked at the sex that was tending to be diagnosed early, the data did not correlate with that. So how this registry works within Sickle in Africa is that all the patients that are enrolled, of course, have to give consent, and this has to be written informed consent to provide data, to register, and as well as to follow up the patient longitudinally. We use an electronic platform and we use RedCap. The data that is collected is centralized so that all the countries feed in their data to the data coordinating center, which is based in Cape Town in South Africa. This way, we are able to share that core data, which I spoke about. And some of this data has actually been published, and we're able to make some deductions about the observations. Of course, there's been a lot of training in bioinformatics, biostatistics, and other different courses related to improving data management as well as improving the clinical skills of managing the patients. Each country, of course, has had to go through the ethics where they have to obtain ethical approval. And within the consortium, particularly for Zambia and Zimbabwe, that are working together, we've had to have a data sharing agreement. But in addition to that, we have to have, as a consortium, each country has to have a data sharing agreement with Sickle in Africa. And I did mention early, there is core data that is collected, but also additional data can be collected by the different countries. Quite a number of publications have already come out of this collaboration or this consortium. We have had Tanzania looking at the characteristics of stroke and outcome in urban Tanzania. We have had in Zambia a study where we have looked at the transcranial Doppler ultrasound velocities of the children that were being registered. And this was possible again because we chose to add a variable of collecting transcranial Doppler results from the patient. And this is something that is not being done by everybody. As an editorial, the Sickle in Africa Consortium has also looked at how they can build capacity for research and healthcare within the sickle cell disease community. So this is just a snapshot of the more recent data that was collected. In the first phase, it was reported over 13,000 patients were registered within the registry. As of, I believe, 2 months ago, about 43,296 patients have been registered. And all these patients have had over 70,000 visits to the hospital. There are reports of the type of tests that are being used to diagnose these patients, and we can see there's about less than 1% having HPLC being used. In terms of the genotype, 82.4% of the patients that are diagnosed with the disease actually have SS. So this is just some of the interesting data that is coming out. We are not yet done. The consortium ends in 2026. So at that point, then we can have much more consolidated data than I'm sharing. So this, again, is just an illustration of some of the data collection that takes place. This was a publication that came out from Ghana, demonstrating how or what numbers they've been having in terms of enrolling patient in the data registry from December of 2017 all the way to February 2021, when the first phase came to an end. Within Zimbabwe and Zambia, I've also shared, we have registered over 2,000 patients. We are at 2,500, thereabout. And these are the things that we have, these are the results that we have found. 2,468 patients have got SS. We have 5 patients that have got SC, and we have 4 patients that we suspect could have beta thal. We've not been able to do the more definitive tests. We also have results indicating that about 68% of patients in Zimbabwe, 64% of the Zambians are actually on hydroxyurea, the patients that are in this data registry. Some of the consortium studies that we have conducted, some still being planned, is that we have done point of care screening for the newborn within all the 7 countries that have part of the consortium. At present, we are doing an observational study to assess the prevalence of malaria in children that are living with sickle cell disease across the 7 countries. Between Zimbabwe and Zambia, we're also planning to do a pharmacogenetic study of pain in sickle cell disease patients, but with the recent pronouncements from NIH and the fact that the grant comes to an end next year, we've not been able to do this. Within Nigeria, they've also done geospatial mapping of the patients that are within the registry. So these are some of the benefits that we have seen. There's been, of course, improved understanding of our patients, understanding the prevalence, the genetics, the complications, and the differences in how we manage the patients. So this is really evidence-based information that we have collected, and we can apply it in the care of our patients. And as I just demonstrated previously, there's been enhanced research as well. Within the consortium, of course, we've noted quite a number of things that have facilitated improvements or the work that has happened within the consortium. There is power in the numbers. So we have a robust database. I just shared with you the numbers that are there. There's been a lot of collaborations with clinicians, academicians, and scientists coming together within the countries and among the different countries that are taking place. We've tried as much as possible to embed the activities that we're doing within the local infrastructure, within health, within education, and within research. We've also tried to work with the existing programs that are there and not really work parallel with them. There's been quite good coordination with organizational structures, operation menus. There's been work plans that have been established. We've also tried to engage key stakeholders, and among this, of course, are the patients themselves, who we are working very close to. They've taken part in workshops, in trainings. We've had trainings with them where we have discussed their thoughts on research and how they can also participate in research as well. We've also been working very closely with the sickle cell disease ontology, which has helped us really define terminologies that we use within sickle cell disease and therefore can speak the same language even as we report our research or as we report some of the data that we are collecting. And of course, the standardized guidelines has enabled us to speak the same language in terms of what we report. There have been challenges as well, some already highlighted. Of course, these are regional registries. Some of the information we have is really just clinical administrative data. There are surveys, there are cross-sectional reports, and all these, you agree with me, sometimes cannot be generalized within a country. Most of this data is either collected voluntarily or it's because of a short-term research project that is going on, so that it will be very difficult to sustain the data collection long-term without continued funding. A number of countries have had challenges with access to internet, which has also been worsened by I think a number of countries having experienced power outages, and internet is very difficult to access, but also in some cases very expensive. This activity actually needs long-term financial support. If there's going to be long-term sustainability, the infrastructure that is required is also quite costly. It needs long-term maintenance. Of course, there is also noted lack of knowledge within the health workers about data management, about clinical care, which will compromise the data set that you're going to collect. Sometimes it's not being clearly defined as to the stakeholders' role, so that issues of trust come in where stakeholders are not sure what role they are supposed to be playing. The legal and ethical frameworks were mentioned. It's very important that the data is harmonized, and it's also very important that the data is protected within the consortium and within the countries as well. We've also had the challenges where patients coming for follow-up is not regular, and sometimes this makes the data have a lot of missing points and also have incomplete data as well. If it's going to be a long-term activity, it is an activity that needs very good supervision, which is easy to do within a research setup, but very difficult to do if it's just routine data that we are collecting within an institution. So in terms of sustainability,
1 minute.
thank you. In terms of our sustainability, we need to link these activities to institutional records and national data as well. We have some stakeholders or collaborators that we are working with where data is being collected within the newborn screening program. For Sub-Saharan Africa, Kwanzaa, there's ongoing data collection. That is a program that has continued. Within the WHO Pen Plus program as well, something that is working within the primary health care facilities of the different countries participating, most of which are countries in the consortium, there is quite robust data collection as well. And we need institutional data regulation and protection. And that is where GANSID also comes in. We would love, as a consortium, to partner with GANSID so that we continue these good works that we have started. So thank you very much for the opportunity to make this presentation. You appreciate that with what has been shared, there's quite a lot of potential within this registry where we can do research, support clinical trial. It can facilitate drug development, it's facilitating biobanking, it's facilitating inclusion in disease control program. It has facilitated connections with patients and also empowering patients to be part of this process of improving their own care. So thank you.
Thank you so much for that presentation. That's wonderful to hear what's happening in those different African countries. Our next presenter is Dr. Jane Little. Dr. Little is the director of the Adult Sickle Cell Disease Clinic at the University of North Carolina at Chapel Hill. She is a professor of medicine and has an interest in the registry development in the United States and internationally, and in hypoxemia in people living with sickle cell anemia. She is one of the founders and co-PI of the GRANDAD Registry in the United States and the Grandma Registry in Malawi, and participates in the Cousins collaboration with the UK. Thank you so much, Dr. Little, and I look forward to your presentation.
Thanks, Dr. Ivy. It's really an honor I'm presenting on behalf of Julie Cantor. And it's really an honor to follow after Dr. Adekile and Dr. Chunda-Liyoka, who gave really great presentations. Can you see the presentation?
Dr. Little,
Or are you seeing
speaker notes,
what?
speaker view. So it's not full.
Let me see if I can flip that. It's more tricky than it looks.
Try sharing the presentation first and then sharing your screen.
Sharing the presentation first.
Going to click present and then click share screen on Zoom.
Okay, let me I don't know quite what you mean, but let me try it. Oh God. Click present where?
Like to play the slideshow.
Play your
Oh, I
slideshow.
see. Yeah, I see. Hang on. In PowerPoint, you mean? All right. How the
I think
computers.
if you press F5, the button F5.
No, I'm on a Mac, so it's
Oh, okay.
it's all hellish. Okay, now swap displays. Maybe that'll do it. All right, let's try this. Give me a sec to get back into Zoom. No. Come on. You can show me Zoom. I'm sorry, I hate watching other people do this, and here I am doing the exact same thing.
All right, no worries. Thank you very much.
The rest of us.
It's so annoying. It just is not doing what I want it to do. Okay, let's share. I'm gonna do this. No, I'm not gonna do that. I'm gonna do this one. Let's see if this works.
Yes.
Now,
Perfect.
or is
Wonderful.
it still?
No, it looks great.
It's perfect.
Okay, great. Yeah, sorry about that. That's taken out about 15 minutes of this 15-minute presentation. I'm presenting on behalf of Julie Cantor and some of the other people who have struggled with the same problem that you've just heard about in Africa, which is really tracking our patients in an effort to improve quality of care and cohesion within the community. So I'm going to describe the GRANDAD registry to you. You all know this, but it's always worth repeating how many faces there are to sickle cell disease and how many ways it can trick us. I think we've especially learned this in the last 40 years in the US when pediatric care improved in around 1960, 1970. And a lot of that was actually politically driven, which is interesting, what a big impact it can have to have the government behind these efforts. And because of that, we then had better care of children who were immunocompromised from the sickle cell, even before hydroxyurea emerged, even before transfusions. You can see that the life expectancy starts to go up. But if any of you have read The Little Prince as children, you remember this little figure of a little kind of funny curve. And you never really know what's under that curve until you get really good data. In this case, it was an elephant, but we don't really know what's under the curve of this new expanding adult population in the US and now worldwide. And also, mortality is still too soon in sickle cell disease, despite improving so many symptoms, I think, and delaying a lot of complications. They're still coming. And this, just to focus on two curves, one is the 1979 curve. So about 35 years ago, you can see a lot of childhood deaths. And then more recently, the red curve is still not great. Like people are still dying in their 30s and their 40s. And it's just not acceptable. And I think we need better tools, both medically and also structurally, to better care for people with sickle cell disease. In the US, there have been other examples, and I'll show you just a couple of quick slides about that, of how registries have really driven developments of better healthcare in cystic fibrosis and in hemophilia. In sickle cell disease, the pickings have been very slim. Hydroxyurea, amazingly, has been an incredibly beneficial drug for children and adults, and seems to be mostly safe, although nothing's perfect. And also transfusions really came to the fore in the first decade of this century, from the STOP 1 and STOP 2 trials to try to prevent strokes in children. But since then, like L-glutamine I don't even know quite how it works, and it's really not used widely. Voxelotor, you all know the story there. And crizanlizumab, I think there are a lot of recent doubts about its efficacy in most patients with sickle cell. And now we have the gene therapies, which are really accessible to just a small crust of people across the world. So, we had 1, 2, 3, 4, if you count gene therapy as one, 5, 6 treatments emerge over the last 30 to 40 years. And now 2 of them are in question and people don't use L-glutamine. That's very different from cystic fibrosis, where maybe they were luckier, but they also had millions and millions of dollars, billions probably, of investment that really drove the discovery of new agents in that disease. So registries have been super important in helping other lifespan diseases figure out how to get better care, how to be part of a community that educates each other and learns from each other, and also how to raise money, be cohesive in some way, and start to develop new treatments. And so if you look at this, this is cystic fibrosis on the left, this is hemophilia on the right. And, this is hemophilia's registry. Yeah, okay, maybe it's a young adult, but this is middle age. Like cystic fibrosis has been doing this for 60 plus years, and it's had a huge impact on the health of their population. Just very briefly, this is a study looking at the iterative quality improvement you could get from having registries and having communications across the community, where you can see the best sites had better survival than other sites. And although I'm sure that if you were one of these sites, you were totally horrified and ashamed to be on this line, I bet you a ton of these people moved up to the green line over time, because having data really helps you understand. Most of us think we're doing okay, but sometimes you're just not. And so I think that's been really helpful. So in the US, there has never been a national approach to sickle cell disease. There have been intermittent groupings that have sort of come together and fallen apart, and they're competing policies, and there's not much funding. And so there has not been until recently a national sickle cell disease registry and no cooperative approach to quality improvement. And nobody wants to be alone when you have sickle cell disease or you're taking care of sickle cell disease. The more community, the better. So Julie Cantor, it's nice that I can give her talk because I can really highlight what an extraordinary person she has been in really encouraging a national alliance of sickle cell centers, which has been really true in cystic fibrosis for, again, probably 50 years or more, and in hemophilia for many decades. And it really improves people's lives. And, even if you can't cure things yet, you can sure as heck make things better. And I think these kind of collaborative communities where you learn from each other and you have a certain set of guidelines that establish what is needed in the community are extremely helpful, I think. NASAC is still in its, not infancy, but its childhood. But I think we can already see that it's going to be very valuable, I think. So what I'll focus on in the last part of this talk is just the need for data when you're going to try to take care of a community in a collaborative way. So data helps you understand what works well, who does it work well for, like understanding which patients benefit from which treatments. It can allow us to predict outcomes. It can transform care in identifying improvement and giving metrics, so giving some shape to the kind of care you're giving. And longitudinal data in a disease like sickle cell, where there weren't adults in the US, there weren't a lot of adults until 25 years ago, is incredibly helpful. The registries in sickle cell, there was a very famous one called the CSCCD, which arose in the 70s before there was hydroxyurea. There have been an enormous number of publications from that registry, and we have learned a ton on how to take care of people with sickle cell disease, but it was not financed in a sustained way by the NIH, which is a real grief to me. And it doesn't really describe the contemporary adult population in the US because there was no hydria and the life expectancy back then was about 20 years less than it is now. And so they didn't really describe the full lifespan. So we really need better data in the US about how to care for people who are now living with sickle cell disease, because the data we have from before probably isn't fully applicable. One grassroots approach that I was part of, there were a lot of us who were part of it about 10 years ago, was the Global Research Network for Data and Discovery, or GRANDAD. I think the strengths of GRANDAD are that it's grassroots, so we're all in. It's also prospective, it's longitudinal, and it's updated annually, and it's multi-site. And the goal was really to get good data. And you've heard that again in the talks today, how valuable data are, how much it improves our ability to take care of people with sickle cell disease. We also want to give iterative data so that we can say to people, hey, you need to do this thing better. Here's how we can help you. Look, these guys are doing a great job. Why don't you learn from them? And so you can have a platform for ongoing quality initiatives and quality assurance. And I think it also allows you to look at these new study drugs that have emerged and said, are they working? Like, is this helpful? And so GRANDAD has become the registry for one of the federal projects, which is the HRSA SCD TDP program, and the National Alliance of Sickle Cell Center. And some of us, myself included, are using it as a sort of platform from which we are completing NIH-funded studies. It was funded by a Doris Duke Foundation grant in 2015. At that time, a number of us got together and sort of figured out what kind of data we needed. I think we need registries to allow access to precision medicine, which is going to become more feasible in the next few decades. Oh, and the session's almost over. So, okay, registries are great. Collaboration is better. And thank you for allowing me to participate.
Thank you so much for that presentation, Dr. Little. We're happy to hear that the challenges are not only limited to the low and middle resource countries. There's also challenges in the US, but we're working together to try to figure out what those challenges are, and then what are some of those solutions that can be applied not just to the high income countries like the US, but also to those lower and middle resource countries as well. Unfortunately, we won't have time for Q&A. Dr. Little, Dr. Chunda-Liyoka, and Dr. Adekile, there are questions in the Q&A. If you don't mind just taking a look at those questions and answering them, that would be great. Thank you so much, everyone, for attending this session. We will have a 15-minute break. If you have not done so yet, there is a survey that will pop up on your screen. We ask that you can please complete that survey. That provides us with information to make sure that we're doing service to what we're trying to do here with getting information out. I'd like to thank everyone for attending this session, and I encourage you to attend the remaining sessions for today, as well as stay participants in trying to determine how we improve sickle cell disease care globally. Thank you and have a wonderful day.